Hello everyone, this is a video of laparoscopic suture rectopexy for a case of complete rectal prolapse in a middle-aged male patient who presented with rectum coming out through anal opening for last 6 months. He had a history of chronic constipation. After proper evaluation with colonoscopy, MR difficography, it was confirmed there is a complete rectal prolapse with rectorectal interception. So, patient was prepared and taken up for laparoscopic posterior suture rectopexy. So, this is the same plane which is entered during the TME surgery. So, after incising the right lateral peritoneum of rectum just above the 2 centimeter above the sacral promontory, I have entered into the slowly by careful dissection. I have entered into the TME plane, safeguarding the hypogastric nerve plexus. You can see I am just doing the dissection just above the hypogastric nerve so that I can bring down the hypogastric nerves toward the sacral along the sacral curvature. And safeguarding this nerve is very important because in postoperative period sometimes bladder bowel dysfunction can happen because of the neuropraxia. So that kind of complication or persistent postoperative bladder bowel dysfunction can be avoided. So you can see the neurovascular, the hypogastric nerves can be seen clearly resting on the sacral promontory and along the sacral hollow. So there is a clear plane which is the same plane between the fascia propria and the presacral fascia, which is a holy plane of Hild that is being entered. There is a loose areolar tissue plane. If we can enter into this plane from the very beginning, we can completely mobilize the rectum posteriorly. And in rectal prolapse surgery, the complete rectal mobilization, particularly if you are doing a posterior rectopexy, the posterior mobilization is very important, and that should be done starting from the sacral promontory up till the levator muscle. So this retrorectal mobilization is being done carefully and staying in the correct plane so that there will be hardly any blood loss, and the complete dissection is being carried out. So continuous mobilization, posterior mobilization is required, and you can see with my left hand instrument I am giving good amount of traction. And now I can see sacral promontory and clear layer of presacral fascia covering all the nerves, hypogastric plexus. So medial to lateral mobilization is also required for complete mobilization, posterior mobilization of the rectum. So you can see while doing the medial to lateral mobilization, we will gradually encounter the left ureter on the left lateral pelvic wall, and that should be safeguarded also. So here a little bit of tissue dissection gradually and staying in the correct plane so that nerve should come down. And I'm trying to find the left ureter which will come in my in the way of dissection, and that one important structure that should be taken care of. So that is the area of ureter. So I'm just seeing whether just touching, trying to see the peristalsis of ureter, so to confirm. And once it is seen, and then you can see the proximal two-third of the rectum posterior aspect is being mobilized nicely. Medial to lateral mobilization till the left lateral pelvic wall being is also being done. And now what we can do is after a little further dissection downwards, I can do the left lateral dissection, the peritoneal division, and the for further mobilization on the lateral aspect also and posterior aspect also, further lateral division of the peritoneum is required. So just giving good amount of traction in the posterior aspect of the rectum can actually help us entry into the correct plane. So now I have kept a gauge piece over the dissected part proximally over the sacral promontory towards the left lateral pelvic wall, and then on from the opposite side I have incised the peritoneum. So here we can see the gauge piece, the transparent through the transparent peritoneum I can see the gauge piece, and the same plane is being opened up from the medial to lateral dissection. The same plane is being opened from the lateral from the left lateral fold. So once it is being done, the further mobilization of the rectum is being carried out, and you can see the pulsation of the ureter at 9 o'clock also. So ureter is far away, so that is one important structure that has to be taken care of other than the hypogastric nerves on the posterior aspect. So now I can take out the gauge piece and I can clearly see the dissected area, and with hook and monopolar energy continuing the dissection in the same mesorectal plane, same plane as the TV plane that is being dissected. So here further mobilization of the rectum on the lateral aspect is being done, and now again on the posterior aspect the mobilization is being carried out. So gradually along the sacral hollow we'll deep down into the pelvis and then gradually rise up and to see the and as we go down the pelvis, we will encounter the levator muscle. So now you can see the we have finished mobilizing the rectum from the sacral hollow, and the levator muscle can be seen, and little bit of mobilization on the lateral aspect is required, so that at the end of the dissection the rectum should be completely out of the pelvis, and we can fix the rectum, posterior wall of the rectum onto the sacral promontory. So this is the most important step in I think in the rectal prolapse surgery, because complete rectal mobilization is required. You can see the levator muscle now here. This is the levator muscle, and once the complete rectal mobilization is being done nicely, and that is the only main step that will prevent the recurrence after rectal prolapse surgery. So you can see complete bloodless area of dissection, and the complete rectum can be taken out of the pelvis and can make straight. And once we can see that the little bit of dissection on the left lateral aspect is required, so I have done a little bit of dissection on the lateral, but we don't divide the lateral ligaments, because lateral ligaments again contain some neurovascular bundles that should not be disturbed, so that the postoperative bladder bowel function should not get hampered. And now once the adequate mobilization, the posterior aspect and the lateral aspect, limited lateral mobilization is being done, the sacral promontory is being confirmed, and now taking a 2-0 Prolene suture, I am doing the Rectopexy. So here with assistant traction, the rectum is being kept completely straight out of the pelvis, and a thick bite with the sacral promontory, taking the periosteum of the sacral promontory and the lateral fold of the mesorectum is being sutured together, so that once the assistant leaves the rectum should lie straight and keeps like that. So again by taking the periosteum of the mesorectum, sometimes it can bleed, but once you put the suture, once they fix the suture, the bleeding will automatically get stopped. So 2 sutures on the right lateral aspect and 2 sutures on the left lateral aspect, that is what is required. So from the left side also I have taken 1 bite with the lateral fold of the rectum, mesorectum, and the sacral promontory. This is 1 bite, and then 1 more bite will be taken. So the suturing is learning proper suturing is very essential, and here the perfect suturing technique is absolutely correct, because this is the main one of the most important part in suture rectopexy, because we have to need to learn the proper suturing technique, so that we can fix the rectum nicely with the sacral promontory, with bites which should be adequately thick, and should be safeguarding all the important neurovascular and structure, ureter, so that should be taken care of. So now you can see it is being tightened, and the rectum is now fixed with the sacral promontory, and the final step is to close the peritoneal margin. So using a 3-0 absorbable V-lock suture, we started closing the peritoneal fold, and very cautiously, so that only peritoneal layer should be taken into the bites, because lateral pelvic wall, there are important anatomical structures are there. So very cautiously and gently this suturing should be done, and also it should be taken care of. There should be no undue opening in the peritoneal closure, so that there should not be any chance of post-operative internal hernia formation. So that is the idea of closing the peritoneal flap, and at the end of rectopexy surgery, this peritoneal closure should be nicely done. and this is the left side suturing is being done. So I can see there is a little bit of still gap is there in the sutured layer. So I will take one more extra bite over there so that I can close the potential space. So here you can see I have taken one more bite to close the peritoneal gap on that side, and once it is done on the left side, the same thing is being repeated on the right side also. So the operation took time around 95 minutes, and there was hardly any blood loss, as you can see. And the operation post-operative period, the patient was extubated and shifted to ward, and then after 4 hours patient is being allowed liquid diet and is being mobilized. The catheter was kept for 1 day, Foley's catheter was kept for 1 day, and the next morning the catheter was removed. And then the patient had an uneventful recovery. The soft diet is being allowed from the very next day, and the patient has passed to on post-operative day 2 and is being discharged from the hospital and is doing well in the follow-up period. So that completes the laparoscopic suture rectopexy procedure, and thank you for watching the video, and keep watching for more surgical videos. Thank you so much.